Welcome to Chapter 8, Interpretation of Blood Gases. In this lecture, we will cover indications for blood gas and oximetry analysis, sampling and measurement, invasive blood gas sampling, non-invasive approaches, assessment of oxygenation, assessment of acid-base balance, simple acid-base imbalances, combined acid-base disturbances, and mixed acid-base disturbances. We will also look at how to assure valid measurement and use of blood gas data, systematic interpretation of blood gases, and oxygenation assessment. So what should you learn after this lecture? You should know how to identify the reference ranges for both arterial blood gas and oximetry parameters. You should be able to identify indications for blood gas and oximetry analysis and differentiate between invasive and non-invasive methods for measuring blood gas and oximetry parameters, as well as be able to explain the key procedural elements in obtaining a blood gas and the means by which to do so. You should be able to apply your knowledge of factors affecting hemoglobin saturation to the interpretation of oximetry data and apply common indices of oxygenation to assess the cause and severity of hypoxemia. You should be able to employ the Henderson-Hasselbalch equation to relate to changes in the PCO2 and bicarb to pH, and describe common causes and compensation mechanisms for expected blood gas findings. You should also be able to describe common causes and expected blood gas findings seen in combined and mixed acid-base disorders, as well as identify common pre-analytic, analytic, and post-analytic errors in blood gas analysis, and methods to ensure valid measurement and use of blood gas data. You should also know how to accurately interpret arterial blood gas and oximetry data. Care of patients with cardiopulmonary disorders often requires special knowledge of their oxygenation, ventilation, and acid-base status. This information is obtained by blood gas and oximetry analysis. Respiratory therapists need to know when and how to obtain the measurements and how to be able to accurately interpret them. In this lecture, we will focus on the interpretation of arterial blood gas results, as well as normal ranges for blood gas measurements. We'll also look at peripheral venous blood gas and how it reflects on local metabolism and mixed venous samples from pulmonary artery and more recently central venous catheter gases, how they can be used to evaluate overall tissue oxygenation. The use of mixed venous blood and central catheter blood for this purpose will also be discussed later. Indications for blood gas and oximetry analysis. Blood gas analysis is indicated if the patient's symptoms, medical history, physical exam, or lab data suggest abnormalities in respiratory or acid-base status. Blood gas analysis can also help evaluate treatment effects and thus be used whenever significant changes occur in therapy that affect oxygenation, ventilation, or acid-base balance. Blood oxygenation can be assessed by either arterial blood gas, ABG analysis, pulse oximetry, transcutaneous monitoring, that is used mainly in infants and children, or hemooximetry. Ventilation can be assessed by ABGs, TCPO2, or capnography. An ABG is required for accurate assessment of acid-base status. Table 8.1 shows sample reference ranges for arterial blood gas parameters. That's on page 145 in your book, and Table 8.2 outlines the key indications for measurements as recommended by the AARC on page 146 in your book. So please be sure to take a look at these important tables. Sampling and measurement. Non-invasive or invasive. Blood gas sampling and measurement approaches can be broadly classified into being either invasive or non-invasive. Invasive approaches require sampling of blood by needle puncture or indwelling catheter. Non-invasive approaches measure blood gas parameters by sensors on the skin, like a TCO2, or evaluation of exchanged gases like capnography. If the goal is to accurately evaluate oxygenation, ventilation, and acid-base status, analysis of an arterial blood gas sample is the gold standard against which other measures are compared. Blood gas samples may be obtained by needle puncture of an artery, which is pictured here, or from an indwelling arterial catheter. Measurement of arterial pH, PaCO2, and PaO2 typically is provided by a blood gas analyzer, which also calculates bicarb and SaO2 values. Co-oximetry is needed to detect the presence of carboxyhemoglobin or other abnormal hemoglobins and actual saturation. An arterial blood gas sample may be obtained from the radial, brachial, dorsal pedalis, or femoral arteries. The radial artery is preferred because it is readily accessible, easy to stabilize, and seldom results in serious complications because there is collateral circulation provided by the ulnar artery. Fine points involved in arterial puncture include checking coagulation-related tests, assessing for collateral circulation before and after procedure, and proper technique to minimize pain and complication. Table 8.2, pictured here, outlines the indications for blood gases and oximetry analysis. It's pictured on page 146 in your book. Make sure to review it. When the radial artery is selected, a modified Allen's test must be performed to evaluate the adequacy of collateral circulation to the hand. To perform this test, the patient is instructed to make a tight fist, then both the radial and ulnar arteries are compressed. Have the patient open and relax the hand, which should reveal a blanched palm and fingers. Next, release the pressure on the ulnar artery while observing the patient's hand for color changes. If collateral circulation is adequate, the patient's hand will pink up within 5 to 15 seconds, a positive Allen's test. A positive result confirms adequate collateral flow and that the radial artery is an acceptable sampling site. If the test is negative and the hand does not rapidly pink up, the radial artery is not an acceptable site for puncture. In such cases, the other wrist should be evaluated, or another site like the brachial artery should be used. Note that the ulnar artery is on the pinky side of the hand. The radial artery is on the thumb side of the hand. Let's talk a little bit about indwelling catheters or art lines, A-lines. Arterial puncture causes trauma, and so an indwelling arterial catheter or A-line should be used when frequent sampling is necessary, like a long-time ventilated patient. As a result of potential hazards of hemorrhage and bloodstream infection, A-lines require careful management, and their use generally is limited to very unstable patients in the intensive care unit. The A-line catheter is connected to a pressurized heparin infusion set that incorporates a pressure transducer, a flush device, a sampling port that is accessed either through a three-way stopcock or a closed reservoir. A three-way stopcock in a vascular line system shows the various positions used. In A, normal operating position with flush solution going to the patient and the sample port closed. Position B is the position to draw a blood gas sample from the vascular line. It's closed to the flush solution. C is positioned to flush the sampling port. It is closed to the patient. In any intermediate position, all ports are closed. Table 8.3 shows the procedures for obtaining blood gas samples from an art line in an adult patient and should be reviewed. This can be found on page 148 in your Wilkins Respiratory Care Assessment book. After the sample is obtained and the puncture site stabilized, the sample is either sent to the laboratory or analyzed at the bedside using a point-of-care analyzer. When using a point-of-care analyzer, the instrument needs to be properly prepared before obtaining the blood gas sample. Normally, this involves verifying its power-up operation, inserting the needed cartridge, and confirming the internal calibration. After the sample is obtained and any air bubbles are removed, it should be thoroughly mixed and injected into the cartridge within 2 to 3 minutes, depending on the manufacturer, and the sample should not be placed on ice. If the analysis results fall outside the analyzer's reportable ranges, results are flagged. The remaining sample should be sent to central laboratory for analysis. Of course, the RT should never wait for repeat results if the findings indicate a life-threatening problem. For example, if the bedside results indicate oxygen levels below the analyzer's reportable ranges and the patient is cyanotic, the RT should immediately start oxygen administration or raise the FiO2 while awaiting test results from the central lab. Measurements. Non-invasive blood gas analysis uses external skin sensors to measure relevant parameters. Pulse oximetry is the most common non-invasive method for ABG-related measurements, though transcutaneous analysis and capnography are used as well. Pulse oximetry is a non-invasive technique for measuring oxygen saturation, or SpO2, of hemoglobin in the blood. When compared with analysis of arterial blood hemoglobin saturation by invasive sampling and co-oximetry among patients with good perfusion, most pulse oximetries are very accurate. They're within 2% of oxygen saturations equal to or greater than 90%. As oxygen saturation falls, SpO2 accuracy also falls and becomes less reliable, necessitating the use of a co-oximeter to accurately determine oxygen saturation of hemoglobin. Pulse oximeters use spectrophotometric principle of light absorption. The standard device probe transmits two wavelengths of light, red and infrared, through capillary beds such as an earlobe or a finger. A fairly constant level of light is absorbed by tissues in venous blood. Periodically, an increased amount of light is absorbed due to an arterial pulse. This yields variable rates of absorption for oxygenated hemoglobin and reduced hemoglobin. The oximeter compares these differences in light absorption and computes the SpO2. Computed in this manner, SpO2 often is called the functional saturation. This simply means the percentage of the normal hemoglobin that is actually bound with oxygen. Pulse oximetry has dramatically reduced the need for arterial blood gas sampling. However, it should never be substituted for blood sample analysis when the clinical situation demands a complete assessment of oxygenation. In addition, because pulse oximeters only provide oxygenation data, abnormalities in ventilation or acid-base balance can go undetected. Transcutaneous analysis. A typical transcutaneous sensor includes an O2 and CO2 electrode and a heating element. The heating element warms the underlying skin to 40 degrees Celsius to 42 degrees Celsius, which increases blood flow and thus arterializes the area. Warming also increases skin permeability and enhances diffusion of oxygen and carbon dioxide from the capillaries through the skin into the electrolyte gel under the sensor. These electrodes measure the gas pressures in the gel using the same electrochemical principles used in blood gas analyzers. Transcutaneous blood gas analysis generally has been limited to use with infants and small children in need of continuous monitoring of oxygenation and ventilation. However, with notable exception of monitoring for hyperoxemia, transcutaneous measurement of oxygen, PT-CO2 monitoring, has been replaced by pulse oximetry. This is because the accuracy of PT-CO2 is highly dependent on the adequacy of perfusion. Low cardiac output, peripheral vasoconstriction, and dehydration all decrease capillary flow, which lowers PT-CO2. And as with PaO2, PT-CO2 does not fully reflect total oxygen content of the blood. Transcutaneous analysis also requires a lengthy setup, calibration, and stabilization. And much training for staff. Capnography involves the measurement of CO2 concentrations or partial pressures in expired gases and their real-time graphic display during breathing. Measurement is based on CO2 absorption of light in the infrared spectrum in proportion to its concentration. A capnograph employs a light source and a photodetector that measures changes in the intensity of infrared light passed through an analysis chamber. The primary application of capnography is to monitor patients during general anesthesia, mechanical ventilation, or resuscitation. As a non-invasive substitute for PaCO2 to assess ventilation, we generally use the end tidal partial pressure of CO2, or PET CO2, although percentage of CO2 can also be used. Normally, the PET CO2 is about 2 to 5 millimeters of mercury less than the PaCO2. VQ imbalances can alter differences between PaCO2 and PET CO2. These imbalances are common in patients with respiratory disorders. Therefore, we normally focus on trending of the end tidal CO2 levels when using capnography for continuous monitoring. Table 8.4 displays common factors causing erroneous SpO2 readings as compared with co-oximetry. Please review this. It's on page 149 in your book. A complete assessment of arterial blood gas parameters indicating the state of patient oxygenation includes the arterial partial pressure of oxygen, or PaO2, hemoglobin content, or Hb, hemoglobin saturation, SaO2 and/or SpO2, and arterial oxygen content, or CaO2, as well as the partial pressure of oxygen, or PaO2. Hypoxemia exists when a patient's P-little-a-O2 is below 80 millimeters of mercury, the lower boundary of the normal range. It most often results from VQ mismatch. The alveolar air equation, or P big AO2, is FiO2 times barometric pressure minus water pressure minus PaCO2 times 1.25. 80 to 100 millimeters of mercury when breathing room air is the normal partial pressure of oxygen, or P-little-a-O2. P-little-a-O2 is the pressure exerted in the blood by dissolved oxygen. The PaO2 reflects the lungs' ability to transfer oxygen from the inspired gas into the circulating blood. Thus, the PaO2 depends on both environmental factors, oxygen concentration and barometric pressure, and lung function. The PaO2 measurement provides clinically significant information as it allows the evaluation of hyperoxia, normoxia, and hypoxemia. Hypoxemia simply means a low oxygen level in the blood. Hypoxemia exists when the PaO2 level is below 80 millimeters of mercury. The PaO2 level determines whether hypoxemia is classified as mild, moderate, or severe. Table 8.5 is pictured here and is on page 150 in your book. Mild is 60 to 79 millimeters of mercury. 40 to 59, moderate. Less than 40, severe. Hypoxemia occurs secondary to VQ mismatch, the most common cause, shunt, diffusion deficit, hypoventilation or slow breathing, inadequate breathing, breathing a reduced partial pressure of oxygen, or hypoxia, inadequate tissue oxygenation. So what's the difference between hypoxemia and hypoxia? Hypoxemia is not enough oxygen in the blood. Hypoxia is not enough oxygen at the tissue level. Table 8.6 shows the types of hypoxemia and their underlying causes. Hypoventilation, pulmonary shunting, diffusion deficit, and low inspired oxygen. Hemoglobin and hemoglobin saturation. Hemoglobin in males is usually 14 to 18 grams per deciliter. Hemoglobin in females is 12 to 15 grams per deciliter. For both males and females, SaO2 or SpO2 is usually greater than 95%. Clinically, though, SaO2 should be greater than 90% and is usually considered adequate if it is. SaO2 reflects the actual amount of oxygen bound to hemoglobin compared with its total capacity. Content of oxygen is the total amount of oxygen carried in the blood. Normal is 16 to 20 milliliters per deciliter. It reflects the dissolved PaO2 and that bound to hemoglobin. 99% of oxygen is carried bound to the hemoglobin. Only 1 to 2% are dissolved in blood. Hemoglobin saturation. Carboxyhemoglobin, or HbCO, the amount of CO bound to hemoglobin is normally none to 1%. It can be measured by a co-oximeter. Carbon monoxide competes with oxygen for hemoglobin binding sites. Carbon monoxide has 200 to 250 times greater affinity for hemoglobin than oxygen. It decreases hemoglobin's ability to bind with oxygen. It shifts the oxyhemoglobin dissociation curve to the left, and for any saturation will release less oxygen at the tissues. Changes in PaCO2, body temperature, and pH cause right or left shifts in the oxyhemoglobin dissociation curves. Changes affect oxygen transport and tissue oxygenation. Factors that influence the oxydissociation curve include shifting to the left increases in hemoglobin oxygen affinity, increased pH, decreased CO2, decreased body temp, decreased 2,3-diphosphoglyceride or 2,3-DPG, the presence of fetal hemoglobin, and the presence of carboxyhemoglobin. Shifts to the right, or a decrease in hemoglobin oxygen affinity, include decreased pH, increased CO2, increased body temp, and increased diphosphoglycerate. This can be reviewed in box 8.2 on page 152 in your Wilkins book. Clinical assessment of oxygen. The goal is to provide adequate tissue oxygenation, evaluate the ability of the lungs to oxygenate blood through ABG analysis and pulse oximetry, and the heart's ability to distribute blood through physical assessment. Hypoxemia is noted by low blood PaO2, low SaO2, and inadequate CaO2. You have to differentiate between the causes of hypoxemia by adding the PaO2 and PaCO2 while breathing room air. If the total is between 110 and 130 millimeters of mercury, then simple hypoventilation exists. If the total is less than 110 millimeters of mercury, then usually lung dysfunction, either shunt, VQ mismatch, or a diffusion deficit exists. Arterial and mixed venous samples are useful in the evaluation of oxygen status by examination of the PaO2, the SaO2, the content of oxygen, and the pressure of venous oxygen. Acid-base balance can be examined by pH, PaCO2, bicarb, and Be. Adequacy of ventilation can be assessed by examination of the PaCO2. The average adult produces about 12,000 moles of acid every single day. In combination, the lungs and the kidneys ensure proper excretion and maintain the appropriate acid-base balance. The lungs remove the bulk of the acid load through ventilation and CO2 excretion. The kidneys remove a smaller amount of acid, only about 1 millimeter per kilogram per day, but help restore the buffer capacity of the body fluids by replenishing bicarb levels. Failure of either system can disrupt normal acid-base balance. Accurate assessment of a patient's acid-base balance is based mainly on interpretation of the arterial pH, partial pressure of carbon dioxide, bicarbonate concentration, and base excess. Interpretation of blood gas measurements. Normal blood gas values include the PaO2, which should be 80 to 100 millimeters of mercury, an SaO2, or saturation level, of greater than 95%, a content of oxygen of 16 to 20 milliliters per deciliter of blood, a pH of 7.35 to 7.45, a PaCO2 of 35 to 45 millimeters of mercury, a bicarb of 22 to 26 milliequivalents per liter, a Be of 0 to plus or minus 2, and a P A to A gradient of 10 to 15 millimeters of mercury on room air. Mixed venous oxygen, or PVO2, should be 38 to 42 millimeters of mercury on room air. Table 8.1 shows sample reference ranges for arterial blood gas parameters. This can be found on page 145 in your book. The mixed venous oxygen sample obtained from a pulmonary artery reflects the tissue oxygenation. Mixed venous oxygenation reflects the balance between oxygen delivery and oxygen consumption. When the PVO2, or mixed venous oxygen, is less than 35 millimeters of mercury, there is strong evidence that there is poor tissue oxygenation. A sudden drop in PVO2 is most often caused by impaired circulation. pH. Normal pH is 735 to 745. Normal blood pH. The arterial blood pH is the best indicator of overall acid-base balance. The pH is the negative logarithm of the hydrogen ion concentration in moles per liter. pH changes this into a more easily remembered number of 7.40. Alterations in pH above or below this normal value can have profound effects on many body systems, especially the central nervous systems. pH values below 735 indicate an abnormally high blood hydrogen ion concentration, or acidemia. A natural byproduct of metabolism is volatile CO2 and metabolitic acids. Thus, the body buffers acids better than bases. However, as acidosis worsens, it tends to depress central nervous system function. And for this reason, patients with acidosis may appear lethargic and disoriented. As acidosis worsens, coma may develop, and significant acidosis may reduce myocardial contractility, cardiac output, and blood flow throughout the body. pH values above 745 indicate an abnormally low hydrogen ion concentration, or alkalemia. The major effect of alkalosis is overexcitability of the central nervous system and peripheral nerves. This can lead to tetany. Extreme alkalosis also may cause muscular spasms of the extremities, face, body, and cardiac dysrhythmias, and even death. PaCO2 is the respiratory component of the acid-base balance. It is the most reliable indicator of effective ventilation. It measures the adequacy of the ventilation relative to the metabolic production of CO2 by the tissues. The presence of a PaCO2 above 45 is termed hypercapnia. Hypercapnia occurs when the level of alveolar ventilation is not sufficient to remove CO2 production, or hypoventilation. A PaCO2 below 35 millimeters of mercury is termed hypocapnia. Hypocapnia occurs when alveolar ventilation exceeds CO2 production, hyperventilation. Plasma bicarbonate, 22 to 26 moles per liter. The plasma bicarbonate, or bicarb, primarily reflects the metabolic component of the acid-base balance and is regulated by the renal system, or kidneys. Because bicarbonate functions chemically as a base, changes in its concentration will cause equivalent directional changes in the pH. That is, if the bicarbonate increases, the pH will rise. If the bicarbonate decreases, the pH will fall. A primary increase in bicarbonate that causes alkalemia, a pH greater than 745, is termed metabolic alkalosis. A primary decrease in bicarbonate that causes acidemia, a pH of less than 735, is termed metabolic acidosis. Bicarb levels may also change as a compensatory or secondary response to primary changes in PaCO2 levels. This usually requires at least 12 to 24 hours to occur, with full compensation taking as long as 3 days or more. Base excess measures changes in total blood buffer base above or below normal. The total quantity of buffer anions in the blood is 45 to 50 moles per liter, or approximately twice that of bicarb. Thus, bicarb accounts for only about half the total buffering capacity of blood. Therefore, BE provides a more complete picture of blood buffering. Moreover, unlikely bicarb acute changes in PaCO2 do not affect BE. For this reason, BE is considered a pure measure of the metabolic component of acid-base balance. The calculation of BE requires measurements of pH, PaCO2, bicarb, and hemoglobin content. Hemoglobin is required in the calculation because of its unsaturated form, or HHB, it can reversibly bind with hydrogen ion, thus serving as a blood buffer. BE is reported as a positive or negative value depending on the direction of the buffer base deviation from normal. The larger the BE, the more severe the deviation in the metabolic component. A positive BE indicates either the presence of excess base or excessive loss of acid. A negative BE, sometimes called a base deficit, indicates either the presence of excessive acid or excessive loss of base. BE will vary directly with the pH. There are two basic types of acid-base disorders, metabolic and respiratory. Metabolic disorders are recognized by abnormalities in plasma bicarbonate, whereas respiratory disorders alter PaCO2. The relationship between these two measures and blood pH is defined in the Henderson-Hasselbalch equation. pH is equal to pK plus the log 10 of the bicarb over the PaCO2 times 0.03. pK is defined as 0.6, a constant. 0.03 is a solubility factor to convert millimeters of mercury to milliequivalents per liter. Normal ratio of bicarb to PaCO2 is 20 to 1. As this changes, the pH is directly affected. You should know that a normal ratio of bicarb to PaCO2 is 20 bicarbs for each one PaCO2. Most acid-base abnormality occur as simple disorders. Simple disorders involve a primary abnormality in one component of the acid-base balance, either PaCO2 or bicarb. Simple acid-base disorders can also involve compensatory responses, by which the component is not primarily affected, to restore the pH back towards normal. Thus, the presence of a near normal pH does not rule out the possibility of a primary acid-base disorder, but instead may indicate the presence of a compensatory response. Compensation for respiratory acidosis occurs through renal reabsorption of bicarbonate. Partial compensation occurs when the plasma bicarbonate is above normal, but the pH is still low. If the pH is in its normal range, it is called fully compensated respiratory acidosis. Once full compensation occurs, bicarbonate levels do not rise further, and the pH levels typically remain in the 735 to 740 range. As a result of the time needed to change bicarbonate levels, compensated respiratory acidosis is also referred to as chronic respiratory acidosis or chronic ventilatory failure. Respiratory alkalosis is an abnormal condition in which there is a primary increase in alveolar ventilation relative to the rate of carbon dioxide production. In other words, hyperventilation or breathing too fast. The hallmark of acute or uncompensated respiratory alkalosis is a reduction in the carbon dioxide in the blood, in association with an elevated pH and normal bicarbonate. Hyperventilation usually is a result of an increased drive to breathe. This occurs with pain, anxiety, and hypoxemia, or a PaO2 of less than 60 millimeters of mercury, or as a compensatory response to metabolic acidosis. Respiratory alkalosis also may be induced accidentally in patients receiving positive pressure ventilation. In other words, we do it by putting in a rate that's way too high. When a respiratory rate is way too high, clinical signs and symptoms associated with acute respiratory alkalosis include tachypnea, dizziness, sweating, tingling in the fingers and toes, and muscle weakness or spasm. Kidneys compensate for respiratory alkalosis by increasing bicarbonate excretion or getting rid of bicarbonate. Partial compensation occurs when the plasma bicarbonate falls below normal and the pH remains above 745. Full compensation occurs when plasma bicarbonate decreases enough to return the pH to the high end of normal range, 740 to 745. Simple metabolic acidosis is an abnormal condition resulting when the plasma bicarb or BE falls below normal. It is caused by decreased production or excess loss of buffers or bicarbonate, or increased production of acid, or decreased ability to excrete acid or hydrogen ion. Compensation occurs by hyperventilation, which occurs rapidly. Lack of compensation indicates a concurrent respiratory defect or respiratory acidosis. Common causes of these two types. Gains in fixed acid load can result from increased metabolic acid production or decreased renal excretion. A reduction in base normally is associated with excessive loss of bicarb. Common causes of these two types of metabolic acidosis include the following: an increase in fixed acid, as in ketoacidosis, like in diabetes or starvation, renal failures in the distal tubules and retention of hydrogen ion, lactic acidosis like in shock or anaerobic metabolism, ingestion of acid like in methanol, or loss of bicarb like in diarrhea, pancreatic fistula, renal failure in the proximal tubules, so you lose bicarb, or in hyperalimentation. Let's talk a little bit about the anion gap. The anion gap differentiates between metabolic acidosis caused by acid gain versus that associated with the loss of base. The major serum cations and major anions, that being the difference being due to the unmeasured ions. The most commonly used formula to compute the anion gap is as follows. anion gap equals positive sodium ions minus negative chloride ions plus sodium bicarbonate. A frequently cited reference range for the anion gap is 8 to 16 moles per liter. It's important to note that the range differs according to whether K is included in the formula and the methods used to measure the electrolytes. For this reason, it is essential that clinicians know the anion gap reference range used at the institution where you're working. Common causes of metabolic alkalosis include the following: hypokalemia or hypochloremia, nasogastric suction, persistent vomiting, diuretic therapy, steroid therapy, excessive administration of sodium bicarb, and certain electrolyte imbalances can lower hydrogen ion or increase bicarb. Hypokalemia promotes migration of the hydrogen ions into the intracellular fluids in exchange for potassium. Hypokalemia can increase renal excretion of hydrogen ions and increase the buffer base. In addition, chloride and bicarbonate ion concentrations tend to be inversely related, and thus hypochloremia is present. The concentration of bicarb usually rises and can cause metabolic alkalosis. Last, gastric suction and vomiting cause loss of stomach acid and can result in alkalosis. Simply stated, a patient with metabolic alkalosis may tend to hypoventilate, so acid-base imbalance should be corrected before any attempt to wean from mechanical ventilation is initiated. Let's talk a bit about combined acid-base disturbances. Combined acid-base disorders are identified easily because the arrangements in PaCO2 and bicarb both drive the pH in the same direction, either low or high. The hallmark of combined respiratory and metabolic acidosis is the simultaneous presence of an elevated PaCO2 and a reduced bicarb, which together can dramatically reduce the pH. Even mild hypercapnia, occurring with a moderate reduction in bicarb, results in profound acidosis. This combined disorder can occur in a variety of situations, including the following: cardiac arrest, chronic obstructive pulmonary disease, and poisoning and drug overdose. Metabolic and respiratory alkalosis. The hallmark of combined respiratory and metabolic alkalosis is simultaneous presence of an elevated bicarb and a low PaCO2, which together will cause a large rise in pH. The resulting combined alkalosis can be severe and may result in serious complications, including life-threatening cardiac arrhythmias. Two clinical situations causing combined respiratory and metabolic alkalosis are noteworthy. Critically ill patients. Respiratory alkalosis is common among patients undergoing critical care. Causes include anxiety, pain, hypoxemia, hypotension, and neurologic damage. Concurrent metabolic alkalosis may develop as a result of nasogastric suctioning, vomiting, blood transfusions, and antacid therapy, as well as ventilator-induced alkalosis. Ventilator-induced alkalosis, also called iatrogenic alkalosis, can occur when patients with compensated respiratory acidosis undergo mechanical ventilation. Typically, these are patients with COPD who have chronically elevated PaCO2 levels who develop an acute on chronic respiratory failure. Their normal acid-base state is a compensated respiratory acidosis, and delivery of inappropriately high volumes or rapid respiratory rates may cause a precipitous drop in PaCO2, resulting in respiratory alkalosis. Metabolic acidosis and respiratory alkalosis are more difficult to identify. Each abnormally usually compensates for the other. Suspect a mixed disorder whenever the degree of compensation is more than expected. Critically ill patients are more likely to have this combination of acid-base disorders, and prognosis is poor. Metabolic alkalosis and respiratory acidosis. Suspect a mixed disorder when the degree of compensation is more than expected. pH of 7.40 with significant changes in PaCO2 and bicarb indicate a mixed disorder. This form of mixed acid-base disorder seen in COPD patients who retain CO2. Steroid and diuretic therapies often cause metabolic alkalosis. Let's talk a little bit about ensuring valid measurements. How do we ensure a valid measurement and use of blood gas data? Blood gas results are used to make critical decisions, and so measurements must be accurate. Their interpretation must be valid, and their application to patient care correct. Errors in any of these areas can result in poor patient management and unsatisfactory outcome. Avoiding errors in measurement and use of blood gas data requires comprehensive quality assurance program. Such programs are designed to ensure quality in sample acquisition and handling. In the pre-analytic phase, we can reduce pre-analytical errors, which means calibration, use, and maintenance of the measurement device. In the analysis phase, we can prevent analytic errors, and in the post-analytic reporting, we can prevent post-analytical errors, interpretation, and use of test results. Avoiding errors will ensure the blood gas data's accuracy. Blood samples obtained by invasive sampling are analyzed either at the bedside using a point-of-care device or in a central laboratory using a benchtop analyzer. In either case, it's essential that the sample provided for analysis be free of pre-analytic errors. There should be no air in the sample. The sample should be an arterial sample, not a venous sample. Dry heparin should be used, and it should be analyzed immediately or iced. The blood gas quality control measures should be followed to help avoid errors during sample analysis. To minimize analytic errors requires regular calibration of the measurement device. Calibration involves exposing the analyzer to calibration media at 2 or more known levels of measurement. For example, the calibrating media for a standard blood gas analyzer includes precision mixtures of oxygen and carbon dioxide gas and buffer solutions with known pH values. During this automated or semi-automated process, the analyzer adjusts its output to correspond exactly to the calibration media's known values. An additional component of laboratory quality control is proficiency testing. Proficiency testing involves blind testing of samples distributed by a central site. Once analyzed, results are returned for review and validation. The central site then sends a report back to participating laboratories for inclusion in their quality assurance documentation. If you have any questions, please reach out to me or ask when you see me in class. Have a great day, and I hope you enjoyed this lecture on blood gas interpretation.